It's Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The next theme is on novel perspectives and treatment strategies for ADHD. Today, Dr. Andy Cutler interviews Dr. Greg Mattingly on guidelines for treating ADHD online. Let's listen in to part 2 of our theme, the challenges of treating ADHD online.
Hello and welcome to another edition of the PsychopharmaStahlogy Show. This is an NEI podcast featuring the one, the only, Dr. Stephen Stahl. So, Steve, how you doing today?
Well, I'm doing great, and good thing there's only one of us, but we have the one and only Greg Mattingly joining us as well.
Yes, we do. Dr. Greg Mattingly is a very good old friend of mine. I should say very good friend. I don't like using the term old, but he's a good friend of mine. And Greg and I, between us, have probably studied every ADHD medication there is, and even some that didn't make it. And Greg is the incoming president of APSARD, the American Professional Society of ADHD and Related Disorders, which is the premier organization for ADHD. So, Greg, how are you?
I'm doing great today, Andy, and glad to join you guys.
Yeah, well, welcome. Well, let's just dive right into it. We're going to be talking today about the challenges of treating ADHD online. Of course, this is going to lead to a broader discussion around the whole issue of stimulant use and misuse and diversion. Let's set the stage here, Greg. What happened with the onset of the COVID-19 pandemic? How did that change how we deliver mental health and then, of course, ADHD?
You know, I think a couple of things converged right at the time of COVID, Andy. We knew that, number one, awareness of adult ADHD, something that 20 years ago we didn't talk about. We talked about kids, we talked about adolescents, but in the last 5 to 10 years, adult ADHD has really come to the forefront. So we'd seen an increased diagnosis of adults that were struggling with ADHD but had never gotten treatment. Right at that same time, then, we had the COVID lockdown, where all of a sudden people had to start working from home, taking classes from home. Your kids were at home doing classes. You were having to use technology now to link into your workplace. And so people that had cognitive challenges, all of a sudden it came right to the forefront. I'm having to use technology. I've got to be present. My mind has to be on it. I have to be able to process information, not get distracted. And I can see that I'm struggling. I'm struggling to keep up. I'm struggling to manage my kids. And I see my kids are struggling. So I think it was a confluence of, number one, increased recognition of adult ADHD. Number two, increasing technological demands. And then number three, our current digital world depends on cognitive capital.
Yeah, exactly. And that's really the issue with adults. Also, adults with ADHD, I guess everyone with ADHD, does not have a lot of good internal discipline, and they need sometimes external structure. And now all of a sudden, people are not going to the office. They don't have their routine. They're at home. They can get distracted and this kind of thing. So I think it all, like you said, it just all converged. And we were already starting, as you said, to recognize that our previous estimates of the persistence of ADHD into adults were really vast underestimates. Greg, I don't know about you, but in my training, there was no such thing as adult ADHD. We were trained that you outgrow it as a childhood disorder, which it doesn't make sense, does it?
No, 100%. Andy, you and I have shared enough, teaching time together and research time together that, even when we first started our careers, we used to teach that this is a disorder more of boys than girls, that, 60% maybe would continue to have as adults, but most of those would be mild, but we missed it. We just missed it. We know that when you look at ADHD, we now know the persistence is somewhere around 90% if you look at cognitive issues. And we know that by the time you get to be an adult, women and men are equally prevalent when it comes to having adult ADHD.
Yeah, and that classic article by Maggie Sibley and colleagues in the Journal of American Psychiatric Association that you and I have discussed many times, it shows something interesting. If you follow people longitudinally rather than just a point prevalence, one point in time, over 90% of people have it, but it can wax and wane depending on the environmental demands. And of course, as we've been saying, COVID-19 changed the whole thing and raised the cognitive demand tremendously. and the stress level. I mean, now maybe you have kids who are not going to school and you had to deal with the kids and your job, everything like that.
Yeah.
So
100%. I think one of the key things for the audience out there, Andy, is, ADHD is a certain number of symptoms, but it's those symptoms causing impairment within your current life and your life circumstances. And I think that impairment comes and goes for some of our patients, depending on the environmental context. If I'm laying in the backyard looking at the clouds, Stephen, I'm probably pretty good with ADHD, pretty creative. I'm thinking of all kinds of things.
Yeah.
But if I have to go inside and pay the bills or help my kids with homework, or maybe think through tomorrow's strategy about what I have to do to organize myself, all of a sudden ADHD shows up again.
It's so true. It's so true. And it can rear its head in many ways. And of course, adults can compensate for this. When you're a kid, of course, you're placed in school and that's not playing to your strength. But as an adult, you can compensate. And until at some point things change and you can't anymore. Let's talk about, treating ADHD is a unique challenge with telemedicine, of course, because some of the drugs, most of the drugs we prescribe are controlled substances, stimulants. So how would you say, Greg, and you see a lot of patients, how did you switch gears here and start using telemedicine to treat ADHD?
We had never used telemedicine in my clinic, and I work with a group of doctors, nurse practitioners, therapists, and we have a research team. We'd never used telemed until COVID.
Yeah,
and all of a sudden, like everybody else, we converted about 90% of our patients over to telemed. And in particular, ADHD. ADHD was a place where you could see people over, a screen. You could fill out rating scales with the ADHD-RS or the Connors. And we did a lot of our visits by telemed. I think some of that was really good for our patients. We were able to reach in and see a college student away at university and make sure they were doing okay. I could see a kid that had ADHD plus an anxiety and see them in a place where they felt comfortable. But we also know that we miss certain things. And sometimes that certain thing is comorbidity, maybe substance use, maybe something that our patients are reluctant to discuss with us. And it's a little harder to pick those things up with a telemed appointment versus an in-person appointment.
That is very interesting. I hadn't thought. How about the challenges of prescribing medications?
So the challenges, I think, now with digital prescribing, whether you see them in person or you see them by telemed, it's all electronic prescribing.
Mm-hmm.
We know there's certain barriers around that, having to do monthly prescriptions. And you have to have kind of a framework within your clinic if you're taking care of a lot of people with ADHD. But how do we get those refills on a timely basis? We make sure the right people are getting their medicines, and we make sure they're not getting medicines from other places that they shouldn't be getting. And I think one of the things that we have, started doing is during COVID, we started seeing new patients through telemedicine. People needed it. We had kids at university, we had college students, we had adults, we had young kids that were struggling. So we used initial appointments with telemed to initiate the treatment of ADHD. And I think one of the questions is whether or not we're going to be allowed to continue doing that in the future. And it looks like the guidance is going to change to where we have to have those initial appointments once again in person.
Yeah, and of course, we also had the rise of these websites, such as Cerebral, you and I have talked about before. And I think this caused problems, didn't it?
It's an interesting thing. So as clinicians and people sitting on the outside, it's easy to be critical of these online telemed platforms. But when you talk to consumers, patients that are struggling with depression and ADHD and other mental health conditions, they say, guys, there's not enough providers out there. When I called my local community, it was 6 months to get an appointment. My kid is struggling today. I can't wait 6 months. What we also found, Andy, is in certain parts of the country, the prescribers that are there don't take insurance. So we had patients in certain communities where there were no prescribers that would take their insurance. So I think they were forced to some of these alternative models about how to access care.
This is exactly something I agree with, Greg, but I also hear from criminal justice and DOJ types that they think that we are tireless advocates for people to a fault, and we're allowing diversion to come in. And unfortunately, sometimes it's considered to be like giving people fentanyl, and they want to crack down on it because it can't possibly be that all that Adderall shortages and all this spike in prescribing was legitimate. So what do we do to reassure that, or to make sure that we actually aren't fooling ourselves, and in some cases anyway?
I think there's a couple of practical guidances. And I've been working a lot with various advocacy groups and with APSARD, the organization that I'm heavily involved with, and Andy's been involved with as well. And I think number one is when an adult comes in for a new evaluation, be leery of using short-acting stimulants. If someone's wanting to misuse or divert compounds, primarily what they're looking for is short-acting stimulants. So in those patients, one of the ways to avoid some of the problems is say, listen, let's talk about medicines that have FDA indications for adults with ADHD. And those would be the long-acting stimulants, the once-daily stimulants, or the non-stimulant compounds, of which we now have 2 approved for adults with ADHD.
Yeah, completely agree. But some of these online platforms, Greg, I completely agree with you that we need to expand access, and that's certainly an advantage of telemedicine. Some of these platforms, the evaluations were very short, and it was very quick to pull the trigger to prescribe, and unfortunately, they did prescribe a lot of immediate-release Adderall.
Actually, let me amplify that. The issue is not just necessarily doing a longer evaluation at the beginning and not using short-acting stimulants. It's in the follow-ups. Because if you don't do much follow-up, it's only online. They get a prescription by just calling in. You never talk to them again. So part of the shaping of understanding what's your patient's legitimate or not is not even on the first face-to-face, which is what everybody's talking about. How about the follow-up?
100%, Steve. It's not a one and done. So this is not a, hey, I think you have ADHD. Let's get you on a stimulant and I'll see you in 5 years. This should be an ongoing journey with your patients. How does ADHD affect you in the context of your life, Andy, as we were just talking about? Where do your symptoms, where do you see them? Where do you not even know that ADHD may be impacting your life? I know it affects me at work, but how about at home with my kids? How about in my marriage? How about impulsively spending and not saving money the way I should? How about impulsively eating? One of the highest genetic cross-links, Steve, and we've talked about it, is the cross-link between ADHD and eating issues and weight.
Well, having said that, Greg, to what extent should we encourage people to get others that are in the patient's life to give us input, both at the initial appointment, but especially a follow-up to actually see what these things are that maybe the patient's not aware of, but people around them might be?
100%. So we now use in our practice, we call them mental health vital statistics. And every new patient gets 5 different vital statistics. The ADHD-RS, the PHQ-9, the MDQ, the GAD-7, and a screener for trauma. And we ask them to fill it out with their significant other. Because quite often their significant other will see things they may not even notice. And let's use the example. I'm an adult with ADHD. I've lived this way my entire life. I may just think some of the things I do are normal and everybody does them. Mm-hmm. And my spouse says, hey, wait a minute. Not everybody gets mad every morning because they can't find their car keys. Not everybody blows up with their kids when they're trying to help them with homework. Not everyone has a hard time shutting their mind off and falling asleep at night.
Yeah, you're talking about normalization bias. And also, let's remember that the parts of the brain ADHD affects are parts of your brain that have to do with self-observation, judgment, insight, and things like that. So yeah, I think that's a wise practice, Greg.
So I guess what I'm hearing is that one of the ways to protect against criticism that we're being cavalier about diagnosing and treatment is to make sure that the evaluation is longer at the beginning and not cursory, that it involves input from others, that we don't use short-acting stimulants right out at the bat in a patient who's unknown to us, particularly an adult, and that we actually have, follow-ups that are not just people calling in for their prescription renewals, at least for maybe a couple of months afterwards. Is that what you would say?
I would give one other one, Steve, and that is don't just treat the chief complaint. The chief complaint these days, and especially in the era of social media, may be something they saw on TikTok or Facebook or one of the social media platforms where they come in and say, oh, I think I have this. Well, they may, but they may have a lot of other things as well. And that may just be the tip of the iceberg of what's going on. So don't make the rookie mistake and treat the chief complaint. Look and see what's underneath that's causing the issues in somebody's life.
Boy, Greg, that's a really good point. And as you and I know very well, ADHD is a disease of comorbidity. The vast majority of people have other things, and sometimes the adults present with the comorbidity with the depression or anxiety. So I think that's really wise to the whole picture as well. And then something you've taught me, Greg, I have to be honest, is don't just focus on the negatives and the impairments. Look at the positives. These are people who usually have developed coping strategies. They have strengths, and we need to amplify those and not throw the baby out with the bathwater.
100%. And if there's anything I'd love for our listeners to go home when we get done with this is when you see a new patient, start with strength-based models. Let me get to know you. What are the things you like doing? What are the things you're good at? Tell me who you are. What do you want the next chapter of your life to be? And as you get to know them, then start looking for the places where they're having problems. So maybe I'm really social. Okay, but how do you do as far as maintaining relationships in the long run? How do you do with modulating your temper? How do you do with getting distracted? How do you do with, you show up to the job, you get the job, but how do you do with holding the job and keeping the job?
Yeah, and people with ADHD can be quite creative. They can be charming. They can be fun. They can be impulsive, which is fun at first, but gets old after a while. Hey, I want to shift gears just for a sec. Greg, how about, we don't just prescribe stimulants in a vacuum. We have to monitor them, and that includes things like blood pressure, heart rate. You might want to weigh the patient. How do you handle that in a telemedicine environment?
It can be challenging. It can be challenging to get some of those wraparound things that we do want to look at. So in kids, I want to look at weight and height. I want to check those at the beginning, and I want to map those out over time because we know that stimulants can cause appetite suppression. There's a lot of data out there that if you're causing appetite suppression, you also cause changes in not staying on your growth curve. So I want to watch that with my kiddos. With my adults, especially adults who have a history of cardiovascular things, I want to check blood pressure. And I'll have to say, I don't routinely check blood pressure on all of my adult patients. But anybody who has a history of cardiovascular illness, I do want to check blood pressure and watch those over time with my adult patients.
Do you trust self-reports online?
I will trust those versus nothing else. And the good news is now our patients can get electronic spigs that are reasonably accurate for getting us blood pressures. Mm-hmm. I probably trust a home blood pressure monitor more than I trust the one that's our local convenience store or something of that.
That's right. That's what I do, Greg. I actually have one myself because I have high blood pressure and I monitor it myself. And my doctor gives me a log sheet and I just write it down on the logs. You certainly can do that. Have your patients get one of those devices. They're very accurate nowadays. Well, I want to shift gears to something else too. Let's talk a little bit, Greg. You mentioned social media like TikTok, and you've presented some incredible data. At last year's ABSARD, you presented just an amazing presentation on TikTok and ADHD and social media. I have to tell you, I was clueless at just how widespread this is. And then I'm going to ask Steve in a minute about what's going on in the popular press. But can you just summarize for folks what's going on with TikTok?
100%. So it's not just TikTok, but it's, all forms of social media. There was a great study, though, that was done by our colleagues up in Montreal, where they looked at the top 100 videos on TikTok that had the tag about being about ADHD. So ADHD TikTok videos. When they looked at those videos, it wasn't that they, were seen by 10,000 people or 50,000 people, but the average of those 100 videos, Andy, was seen by 2.8 million people per video. 2.8. So widespread influence. The average video was about 30 seconds long, viewed by 2.8 million people. The average ADHD TikTok video had been shared over 600,000 times. So we're seeing wide penetration within our population, our younger patients. It's just there. They then broke those videos down, Steve, and it's fascinating the way they looked at it, is they looked at each of those 100 videos, and they had a group of 3 independent people say, are these videos medically accurate? Are they just a personal story? Or are they truly medical disinformation, such as, change your diet, change your ADHD? Exercise more, jump on your bed. I do better with my ADHD. And what they found is 11% of the videos were medically accurate. A big chunk were personally stories, just my personal story of having ADHD, nothing really good or bad about it. But then a larger chunk were medical disinformation. And so I think those things can be dangerous for a lot of reasons. Number one is if you see some, young person jumping on their bed saying, oh, I have ADHD, you have ADHD, we all have ADHD. Then we have people self-referring themselves who may not have ADHD.
Yeah.
If we have people saying, listen, you don't need medicines, just, watch your diet. That'll fix your ADHD. That can be dangerous. And then if we have people talking about, hey, use short-acting stimulants because they'll make you so smart you're going to ace your test. That can be dangerous.
Yeah. Yeah, and you made a very good comment at the ABSARD meeting. We probably need to get on the stick here as professionals and do our own videos, if you will. I've seen Instagram too. It's the same thing. And maybe we could do something a little more responsible here and fight it. I guess the other thing to worry about is, are some of these videos teaching people what to say and how to get in there to get these medicines? And I think that's a big fear the public has.
I think it can be, and it can cut both ways. It's good to have, education about what a condition is and to increase, exposure and awareness. But we also know that we are not lie detectors. So we as psychiatrists were never trained to be measurers of malingering and lie detectors with our patients. I trust most of my patients to be honest with me. If I see things that kind of increase my suspicion that there may be something wrong going on, well, then all of a sudden kind of your spidey senses go up. But I try to be a patient advocate. I try to assume that my patients are being honest and genuine. And I try to assume that most of my patients are coming for, valid reasons to come see me. So it makes it hard when you get somebody who's coming for different reasons.
Well, one technique, Greg, is to not prescribe a stimulant on the first visit and to say, look, you need to come back, because people who really want to game the system and get stimulants, they want it now. They're not going to want to wait and come back and go through a whole evaluation.
100%. And also if you have somebody who's, once again, their chief complaint is, I'd like some Adderall.
Mm-hmm. Right.
That's the person who's not going to get Adderall from my office. That's the person who's going to get a full evaluation. We're going to look to see, do they really have ADHD? And if they do, we're going to be using one of the once daily long-acting medicines to treat their condition.
Greg, before we get into some of the popular press and the misconceptions and the fear people have that this is the new opioid epidemic, let's set the stage for people as to why this is such a serious illness and why it needs to be treated. The mortality rate is higher with ADHD. This is not just something making people spacey. Can you talk a little bit about the medical complications and the mortality rate?
Certainly. And so, Andy, you and I have shared a lot of this information with each other throughout our careers. Mm-hmm. One of my favorite studies was a study done several years ago where it followed adults with ADHD over 2 years. And they looked at me in the months that I took my medicine versus me in the months when I didn't take my ADHD medicine. And they looked at motor vehicle and trauma rates. So this wasn't me versus the population or me versus somebody else. This is me versus me. Does the medicine make a difference? Women in the months that they took their ADHD medicine had 25% less trauma rates due to motor vehicle accidents.
Wow.
Men in the months they took their ADHD medicine had 36% less trauma rates due to motor vehicle accidents. And people that were the most impulsive, that rode motorcycles and jet skis, mm-hmm. the months they took their medicine, they were 50% less likely to have a motor vehicle trauma incident.
Oh my goodness.
So we talk about the protective effect. If, putting on a seatbelt or wearing a helmet decreased trauma rates by 25 to 50%, it'd be illegal not to do it. Taking your medicine decreased trauma rates by that much. We also know that the longer you go with ADHD and you're not getting treatment, Andy, ADHD kind of metastasizes in people's lives, and it becomes not just ADHD, but it becomes ADHD with other health conditions, depression, anxiety, substance misuse, trauma within somebody's life. Because if I have ADHD and I don't feel good about myself, I may choose a partner who maybe isn't a good partner to be with.
Yeah, and
so we see mortality rates, the longer you've been untreated and the more comorbid conditions you have stacked on top of it, mortality rates go up dramatically. So by the time you have ADHD plus 2 other mental health conditions, mortality rates are 8 times higher than the general population.
So early death from a variety of causes of accidents and cardiovascular disease, but also suicide. Suicide rates are higher amongst people with ADHD than the general population.
Suicide and domestic trauma violence.
Yes.
Women with ADHD not getting treatment are 3 times more likely to die as a victim of domestic partner violence.
Yeah.
If I don't feel good about myself, if my life's going down a tough road, I may put up with a partner who doesn't treat me well and puts me at risk.
And there is some evidence for many of these outcomes that treatment does make a big difference as far as mortality, suicide, accidents, all the things we're talking about. Well, Steve, why is it that the popular press is so hell-bent on making this sound like the new opioid epidemic?
Clicks. You don't get clicks for saying, you have an illness that's undertreated, we need to increase medical awareness. You get clicks by saying doctors are overprescribing and patients are abusing it and they're distributing it and yada, yada, yada. So I think that, I'm actually somewhat heartened by the tone of this exploding group of things that came out in Time and the Atlantic and various places, which wasn't as impugning, the treatment of ADHD as wickedly as they could have. The reality is that the conversation you just had the last 5 minutes is really the one that hopefully the listeners will load up on, because it's pushing that this is a serious illness and that it is undertreated and that treatment works. It has to be something we keep putting out there. And while we do that, we already discussed some of the ways we could probably do a better job, at least acknowledging, the optics is almost what we need to acknowledge. The optics of giving medicines too easily with too fast of an interview with not a lot of monitoring afterwards doesn't look good.
Yeah.
And so I think that we need to be attendant to the optics. And I think that if we do that, we will get less pushback. But the shortage of Adderall, more or less was reduced to the fact that a lot of people are getting Adderall who don't need it, and they're abusing it. There's much more complicated than that.
Right.
And I refer you and the audience to the Journal of Attention Disorders that just came out this week by Sibley et al. With Steve Ferrone as one of the co-authors, talking about sudden increase in U.S. stimulant prescribing, alarming or not. And more or less they're saying, no, it's not alarming. It's explainable. During the pandemic, stimulant prescribing actually went down at first as there was sheltering in place, and then it went way up. Now, was it too easy to get stuff online? Can we do a better job? We should always look at the fact of maybe doing a better job and the optics of attempting to do a better job. But the lay press has not been as vicious as I guess I've seen in other cases.
Yeah, this thing flares up periodically. But this is an excellent point. And obviously, and Steve Ferrone is a very good friend of ours, definitely Greg's and mine. I'm a colleague of his. We're both on the same faculty at SUNY Upstate. And he's a very careful and wise person. But I think your point about optics, Steve, is really critical. I really think we're dealing with the PTSD, if you will, of the opioid epidemic. If this was happening before the opioid epidemic, I think it's a whole different conversation. What do you think?
One of the things I would point out for our audience, because it's easy to kind of get the wrong view of this, is that even though awareness of adult ADHD has gone up in the last 10 years and more adults are coming in for treatment, only 1 in 5 adults with ADHD are currently receiving any type of treatment, 20%. So we've moved the needle as far as getting people access and getting people care, but we're still 4 out of 5 people with adult ADHD are not getting care. And we know that adult ADHD carries a higher mortality rate, a higher physical comorbidity rate. Untreated ADHD becomes complicated ADHD with other mental health conditions. And the longer people go without treatment, the more comorbid that becomes. So we've moved the needle on getting more people in, but we're still 4 out of 5 are not getting any treatment when it comes to adult ADHD.
That's a good point, Greg, because I think the reality is we have to prepare the world for the fact there's going to be even more prescribing of medications for adults with ADHD because of what you just said. And that we also can educate that most of the misuse / diversion is not, crushing it and injecting it or snorting it. It's people who want to use medications on an as-needed basis when they think they have to study, if they're in college or work harder, pull an all-nighter at work, and using it in ways that are not correct. Even those with ADHD do that, let alone people who don't have ADHD and get a pill or two from a colleague. That's the problem. It's not necessarily street drugs. It's not methamphetamine.
Well, what's the number one used stimulant in America? It's not Adderall, it's caffeine. So people use caffeine for the same reasons. Caffeine's very short acting. So I think you're absolutely right. Let's talk for a second here. We talked about comorbidity, Greg. Let's talk a little bit about the SAMHSA guidelines. So SAMHSA has guidelines for managing stimulant misuse. And I guess we need to define real quickly, there's abuse, misuse, and diversion. So what are those? And then what does the SAMHSA guidelines say?
Certainly. So, abuse, misuse, and diversion are all kind of overlapping but different terms, obviously, right? And so diversion would be, that's probably the easiest. Mm-hmm. I'm giving it to my college roommate. Mm-hmm. I have ADHD, but I'm giving it to someone else around me. I may be selling it to someone around me, or people may be taking it from me, but that would be diversion. I mean, unfortunately, on college campuses, that can happen quite a bit, right, Steve? We've done studies. There was a study that came out and said, okay, of people that divert their ADHD medicine, where does it wind up being used? And unfortunately, it's not used by itself. It's often used in combination with other substance abuse. Used to stay up and drink too much at night. It's used for those things. So diversion is the one we really want to avoid as much as possible. It's the one we want to stamp out. And if you look at the compounds that tend to be diverted, by and large, it's short-acting stimulants. So one of my guidelines is be very reluctant to use short-acting stimulants, especially on a college campus. When we talk about abuse and misuse, those can be a little bit harder. And I think Steve pointed that out. So if we talk about misuse can be simple things like not being consistent with my medicine, maybe doubling up and taking more on a day when I think I need more, but my doctor hasn't told me to take more.
Exactly.
I'm in the middle of finals and I know my day doesn't end at 8:00. I truly have ADHD, but I've got to stay up till midnight and study. So I think I'm going to take a second dose of my Vyvanse or Concerta or Focalin XR or whatever it is. So that would be misuse. Abuse would be people using it then for the wrong reasons. And abuse can be kind of, milder things like, I'm a girl, I know that I have ADHD, but this also decreases my appetite. If I take a little more, maybe it decreases my appetite more. Maybe I have ADHD, but I've learned that if I take this medicine, I can drink more alcohol on top of it. That would be a case of abuse. And that's one we worry about a lot in my practice because we do see that, especially once again on college campuses where you have to be careful. So I think when you look at those different terms, they're slightly different, but overlapping. I think one of the guidelines is be careful with short-acting stimulants.
Yeah. Monitor
your prescriptions. Make sure people are not getting excessive refills quicker than they should. That person who always seems to have their script eaten by the dog or the medicine got stolen from the car.
Yeah.
You want to be careful with those patients. Now, I do have medicines that have been stolen from patients' cars. I have people that come in with a police report that their car was broken into and their purse was stolen. But be careful with those patients. They live in unstable lives, and it means instability increases the risk of all of these things potentially happening.
I think the public worries that abuse is people just getting high, just abusing it for a high. And maybe there's some of that too. And I think you're right. Studies show that the very small percentage of the diversion or the abuse is people snorting or injecting. It's mostly oral. And there was a study done a few years ago, Greg, I'm sure you know this. We have slides on this, why college students were misusing the medication or the people who got it from their friend. The number one reason was to help me study. It wasn't to get a high. So, and there probably are a lot of people out there, as you mentioned, who are not treated, who are self-medicating by taking their friend's Adderall or something like that. So I think it cuts many different ways. And Steve, part of the problem here is, and this has flared up a couple times in the past, the DEA only allows a certain amount of amphetamine to be put into drug form. They call it API, the active pharmaceutical ingredient. And they haven't really, that limit has not always kept up with the increase in stimulant prescribing. And secondly, as we know, the DEA is very concerned about not allowing this to become the new opioid epidemic. Everybody got caught with egg on their face with the opioid epidemic. So I think it's complicated. And I think some of the drug company manufacturers may also kind of want to limit this and not let it get out of hand.
Again, it's optics. But
yeah.
Adderall is not fentanyl, okay?
Mm-hmm.
And so the reality is that there are also controlled release forms of this. And Greg, maybe it'd be interesting, you see a lot of patients these days. What do you do when they say it's about economics? It's not about immediate release or sustained release. It's just cheaper to get the immediate release. And that's why I want it. And you get some pushback that way. What are the least expensive controlled release ones? And is that an argument that you really need immediate release because it's cheaper?
I think it's a two-pronged argument, Steve. So short-acting amphetamine is fairly cheap. And so that is an issue you'll get into with some of your patients. But let's put it in perspective. With pediatric ADHD, children and adolescents, 80% of our prescribing has been long-acting once-daily scripts. So we learned a long time ago with kids that long-acting once-daily medicines are easier to take. They have more consistent control of your symptoms. You don't forget them. They don't rebound. And somehow when we take care of kids with ADHD, 80% of people seem to be able to afford the once-daily treatments. When it came to adults with ADHD, it was just the opposite. What we found is over half of the treatment was short-acting stimulant. And I think that's what got everybody worried. If with kids we've learned that once-daily long-acting is the best thing to use, why aren't we taking that same guidance when we take care of adults? And adults with ADHD have the same limitations on finance that kids do. So if you can afford it for kids, there's no reason to think that those same parents can't afford it for themselves.
Well, that's actually something that we may need to at least address the optics of, if not clean up, because it does suggest that adults are getting immediate release stimulants for diversion or misuse. And they may or may not, but the reality is if we can convert, and maybe the listeners will have opinions on that, convert more aggressively our adults to long-acting, and particularly for the first time you see them, they don't walk out with an immediate release prescription. They need to have a good excuse for why they need. I mean, you can use them, but we are not doing a good enough job, perhaps, and the optics are bad when there's all this immediate release stimulant use in adults.
I don't think we've done a good enough job making the case for why you need treatment all day with adults. We did a good job with kids. And we've also newer to the game of recognizing and diagnosing it in adults. And I think we're also fooled by some of the compensatory strategies that people have. So I think all of the above are issues. And Steve, I can't agree more. Optics is something we all have to acknowledge. I think we all get defensive because we all know these people need treatment. But we have to recognize how it looks to the rest of the world.
And Steve, I'll say here in our clinic, we have a group of doctors, nurse practitioners, and therapists that all work together. We started about 1.5 years ago, kind of knowing that this trend was coming before we got into the current crisis, converting our adults that were on short-acting stimulant to once-daily stimulants. And it's become a policy in our office that if people call back in for refills, that we're converting people that are on short-acting amphetamine to long-acting medicines before we got into this current crisis. That's done a couple of things. It's made our clinic a little bit easier when it comes to our patients being able to find their medicine because the long-acting medicines have had a little better supply than the short-acting ones, which are in such a crisis right now. I think it also helps to mitigate against some of the criticism that, hey, you're just prescribing short-acting stimulants to people that maybe shouldn't be on them.
Well, I think there was I want to reemphasize 2 points that you guys made jointly. One is that's a real great leadership position for how you practice ADHD in the modern world that Greg just came up with. And, and so let's follow this lead and convert more of our adults to longer acting stimulants. And the other is Andy's, which is to educate the adults that that's a good thing and that they need medication, not just PRN, but that it is best for them to have a long acting coverage. And so if we did both of those things, I think we would mitigate the risk. I mean, I'm worried that with these changing of guidelines that are coming out for how we're going to be able to prescribe online, that there's a bit of a backlash being pushed by government sources that says, these platforms are used to abuse. Let's really nail them down, screw them down tight, and make sure that this doesn't happen. And meanwhile, what happens is that you lose the ability to prescribe without a face-to-face appointment. You lose the ability, perhaps, to even prescribe stimulants at all. And then the follow-up appointments can be much more difficult. So we want to keep options open. In order to do that, we got to do what Greg does in his practice and what Andy just said in education.
Yeah, I like to tell patients, I don't want to be on the road with you when you're not on your medicine or if you're on immediate release and it wears off in the afternoon. You guys are a part of a group that are working on developing expert consensus guidelines for telemedicine and treating ADHD. Can you guys talk a little bit about this process and what you're doing?
Well, I mean, Greg is involved with two groups. One group is his ADHD group that is writing them for adults in general. The United States has been a little late to the party in making guidelines for adults. In fact, we were late to the party in even making diagnostic criteria in DSM with adults. So he's a leader in that, and he also is leading a push to actually say, what about specifically online? And I'm involved in the latter one.
Yeah.
Then we put together about 15 experts and circulated ideas with also some surveys as to what they thought was the right thing. And that'll soon be coming out for publication. And the other group, I guess, is still a little earlier in that process, but the hope is there'll be some guidelines for adult ADHD. So you want to amplify on that, Greg?
Yeah, certainly. Yep. So APSARD, which is our American Professional Society for ADHD, we have guidelines right now by the American Pediatric Association on childhood ADHD. What we have not had in the United States ever is any kind of guidelines about how do you manage adult ADHD? How do you screen for it? How do you look for it? What should treatment be? What is holistic treatment? We did have some expert consensus guidelines that came out about a year ago that Dr. Ferone was the lead author and I was one of the contributors that were global guidelines, but we haven't had anything that's said here in the United States, given our options, what should we be doing? So APSARD is working on those right now in conjunction with a number of our other kind of stakeholders in the adult ADHD field. Those guidelines hopefully will be coming out in the next year or so. What Steve then mentioned is, we got to talking, just a group of us, and said, let's put a group of experts together, experts from various walks of life, doctors, nurse practitioners, people that are academic experts, clinical experts, and talk about where do we as experts in the field of ADHD think that telemedicine has a place to play in this field? How do we help to expand coverage, but do it in a way that's safe? How do we help to mitigate against diversion? How do we make sure we're screening for comorbidity? And so that's a piece that, Steve and I and some others, names that are known to everybody in the field of ADHD, are all working on right now to hopefully give us some guidance about what do we think in the field. I'll comment on one thing, Steve and Andy. This is a place that I have big concerns about what's going to happen in about a month from now. In that the Ryan Haight Act, which allowed us to see somebody for an initial appointment by telemed, then prescribe a medicine that was a controlled substance if it was needed. That was, taken away during COVID in that we were able to see people by telemed and see them and give a controlled substance if they needed it. That's going to come back into bearing as of May. And so if you have not seen somebody in the past year in person in your clinic, there may be barriers to be able to continue them on their current medicines.
Yeah.
And Steve, I can see just a tsunami of patients that may be out there having been managed by telemed that have access to their medicines come May.
Right. And I guess the question is, Greg, I don't know whether these guidelines are going to allow it. If you want to see somebody face to face, can the follow-up be done by someone else who hasn't seen you face to face? And then, because the places where people can see somebody for face to face in rural areas and other urban areas where they're, like you say, and also cash practices are limited. But if we can get somebody else to see them, maybe they can be followed either by telemedicine or online by somebody else, or maybe they're going to have to require the person who gives the follow-ups to actually have seen them face-to-face as well. I don't know.
Yeah. My reading of those guidelines, at least proposed at this point, is they're going to want the person who saw them in person to be the same person that sees them by telemed.
Yeah, I'm sure that's true.
But that's going to be a tough process because let's think about the world we all truly work in. I see somebody in person, but maybe next month I'm away on vacation or I have an illness in the family and they need to be seen by somebody. Does that mean somebody else in my practice who's cross-covering couldn't see the patient? That certainly doesn't seem like a very viable option to give the best care for our patients.
Well, if you're talking about monitoring stimulants, though, certainly the person, anybody in your practice, Greg, can monitor side effects, can check blood pressure and heart rate, weight, things like that, and maybe do a temporary refill, a month refill on the prescription and have them come back or something like that. I definitely hear your point. It is very difficult, though, because in primary care, I know they're taught they have to see a patient on a stimulant every 3 months because they need to check in. Because and do blood pressures and things like that.
But let me point out to the audience too, because it's easy that we get, overly heavy and overly negative in this, and we miss the upside. Andy, why is it that you and I are such advocates for taking care of people with ADHD?
Because it's fun to take care of people with ADHD. You can really get them better, make a huge difference in their lives.
It's the place where you get to make some of the biggest differences in your patients.
That's right.
Steve, I have kids that I've taken care of who are struggling in high school, and I have one right now who's in his second year of residency. That journey in life would have never been the same had we not gotten him on the right treatment for his ADHD so he could be the most successful given his own innate abilities that had gotten off track because of struggling with ADHD.
Yeah.
And so I think, being part of the journey with people ADHD, they think in unusual ways. They're creative. They're fun to take care of. Once you help them to understand who they are and what they are and how ADHD affects them in their life.
Well, ADHD patients in general have vast potential, and often more than some of the other patients we see in psychiatry, like psychosis or whatever. And the medicines work a lot better than they do. Maybe,
That's right.
antipsychotics actually certainly work, but they don't restore you to normal. So the chances of making a profound difference in somebody's life, is really the nature of the illness and the nature of the current treatments for it is really fun. It's why you went into mental health, I think.
Well, there's another issue, guys, we need to talk about. To your point, Steve, stimulants have the highest effect size of any treatment that we have. It's 0.8 to 1.2. But the problem is we would all love to use non-stimulants, but their effect sizes are more in the 0.5, 0.6 range. So we all know that they're not quite as effective. But yet, Greg, should we be using more of non-stimulants now that we especially have another one?
I think we should definitely have the non-stimulants as one of the tools in the toolbox.
Mm-hmm.
And I think one of the things with the non-stimulants, and you and I have both been a part of research looking at a number of those non-stimulants, Andy, is, you're not going to get the same effect in the short run,
mm-hmm.
but if you stick with them in the long run, people do quite well with the non-stimulants.
Yeah.
And so I think that the game there is it's the long game. It's not my, I'm on the first down and I'm trying to get 10 yards. It's I want to win the game over 4 quarters. So what's my long-term play with using a non-stimulant? And you can use a non-stimulant along with other medicines. It doesn't have to be either or. So sometimes a non-stimulant is my base of coverage, and I'll use whatever I need on top of that base. But it's something that's there 24/7 that doesn't disrupt your sleep, that doesn't disrupt your appetite, and helps to give you some symptomatic improvement 24/7 within your life.
Also, there's special populations. For example, those who've had current or even past stimulant or substance abuse.
Mm-hmm.
Also for people who are incarcerated. We see long-term patients in state hospitals and prisons that you can't put a stimulant anywhere. They'll get beat up and have it taken from them. But non-stimulants don't have a street value necessarily. And there's a lot of people with ADHD in those settings. We see some of those in the state hospitals where I consult. And then I guess finally, the non-stimulants might actually work better for some comorbidities.
Right.
So ADHD travels, in a group of other psychiatric problems. And so we should probably give some more serious attention to the non-stimulants.
Well, that's a good point. Especially the newest one, viloxazine extended release, was actually an antidepressant in Europe for many years, whereas the other non-stimulant approved for adults, atomoxetine, failed as an antidepressant. So we have one now that really does work for some of the comorbidity, depression and anxiety. Greg, I love your point, though, about I think this is another educational issue. With a stimulant, they work fast. There's a bang to them, And we're really need to educate people, hey, this isn't going to be like that. This is a longer-term thing, and you're going to be building on your strengths. So it's an education issue.
100%. And Andy, you've seen a handful of my patients who have been willing to give testimonies about their improvement with stimulant medications, but also with some of these newer non-stimulants. And over the course of a long journey, over the course of a year, 2 years, 3 years, seeing some of the transformation you see in people, not just as far as doing well in school, but doing better in their family, doing better in relationships, doing better just with their own self-esteem and self-image as they learn about ADHD on that journey. And you can see some big improvements with the non-stimulants when they're used correctly in those patients.
Another issue when we're talking about adults with ADHD, Greg, is especially those who were not diagnosed as kids. I find that there's almost always an issue of grieving when they realize, wait a minute, you mean I had this condition that could have been treated and it could have changed the course of my life? Self-esteem always takes a big hit with this condition. How do we handle that?
I think it's, walking through the past but inspiring hope. And I would go back to that strength-based model, Andy. Okay, they've had difficulties. That's why they're coming to see us. No one comes to see a psychiatrist or a mental health practitioner because they feel like everything's perfect in their life.
Right.
They're coming in with a problem, and that's why we're there. So our issue is to talk about what makes them unique, what makes them who they are, What's the special sauce that makes you who you are? And now let's talk about where we want this next chapter to be. So, we acknowledge the trauma, the things they've gone through, maybe the struggles they've had. The goal always when we take care of patients is then how do we use that to inspire hope?
Yeah. I think we have to encourage a grieving process and a reorientation and figuring out, what's me? What's the ADHD? What was going on? And then you can move forward with the rest of your life and do quite well. And I love what you said about reaching potential. I think that's what it's really all about. It's helping these people to reach their potential.
Yeah. And the potential with ADHD, it may be somebody who's creative but horribly disorganized. Mm-hmm. How do I use my creativity and learn to, develop tools, tips, tricks for being a little more organized? Instead of running around in the morning and I'm late for work because I can't find my car keys. Well, I stick my car keys on a hook right by the front door. And as soon as I walk in, I stick it on that hook. Because my brain isn't going to help me to remember where it is. So I have to use these artificial things to help keep my daily structure.
Greg, this is a huge point that we need to make to balance out this issue of stimulants. And that is, you don't throw pills at people and fix problems, or pills don't teach skills. So I think in the holistic care of people with ADHD, we've got to go beyond the medication and help the public understand that we're not just throwing pills at people here. There's many other things that we do to try to help these folks.
I'll say there's one other thing, Stephen. I know you've written about this, and you and I have written some articles recently about words matter. But when we talk about treatment isn't in a vacuum. And so we talk now about the dyadic response of treatment. And your dyad are the most important people in your relationships. Who are those people around you? Is it your spouse, your kids, your significant other, your most important relationships? And when I treat one person in a dyad, Andy, I don't just help them. I help the entire group around them.
Yeah.
So when I treat an adult with ADHD, they're doing better, but their kids are also doing better.
Yeah.
Because if I'm running around with my hair on fire, my kids are going to run around with their hair on fire. When I treat a child with ADHD, one of the landmark studies by Russell Barkley, when I treat a child with ADHD, he didn't measure how the kid did. He measured the impact on the mom. And the mom was more likely to spend more time with her child. She was more likely to reach out and tell her child she loved them versus getting mad and scolding them. The more mom was less likely to feel stress within herself because her kid was doing better. So it's that dyadic response when we talk about holistic treatment when it comes to ADHD.
Well said. Well, let's bring it around now, back full circle. Let's bring it around to talking about treating ADHD online. And there, obviously, if you're working on guidelines, but what are the challenges in developing these guidelines? What are some of the pitfalls here, if you will?
I think any guideline, you want to be careful because we don't want to be overly prescriptive to where it limits other options. We know that medicine is not a one-size-fits-all solution for patients. If it was, they wouldn't need us.
Right.
It'd be one treatment, give it to people, and that's all you do. But our patients come in with complex stories, complex histories, and very unique perspectives on what their journey is going to be in life. And Stephen, I've heard you give a talk before where you talk about, which medicines do we use off-label? And the answer is we're always off-label prescribing, right? Pregnancy, yes. Everything's off-label. Postpartum, almost everything is off-label. Many of our medicines we use for kids for ADHD, we use them off-label in adults because we've learned to use them, and the vice versa. When I treat depression in kids, many of those medicines are off-label, but I've learned to use them in adults, and now I'm trying to see could they make a difference for kids.
Sure.
Excellent points. Excellent.
Yeah. Not to mention doses that are outside of the recommended dosing range, and this is definitely an issue with stimulants because, Greg, for years when we did these studies, the FDA was pushing down on stimulant doses. People may not realize the only dose FDA approved for Adderall XR in adults is 20 milligrams. It's 100%. Not a range. Yeah, it's 100%. Very strange. Yeah,
and I'll use an off-label place that I prescribe quite often, Steve, is I'll use a combination of a non-stimulant with a stimulant, and I'll use those together. And quite often my attempt is I want to mitigate against having to use atypical antipsychotics for kids. So a stimulant by itself isn't getting the job done. The kid still has impulsivity, has temper, has mood lability. I'm trying to avoid atypical antipsychotics because of some of the metabolic burdens. And quite often I'll find a sweet spot where a non-stimulant plus a little bit of stimulant on top helps to manage better than either one by itself.
Yeah. Well, coming back to the telehealth, Greg, you said it well. I think a lot of us were in that boat. I certainly was never not using telehealth before at all. And now we've all figured it out, I guess. And now we're kind of coming back to a place of balance where we're figuring out where to fit this into our practice. There are certainly some people I know who have gone all telehealth. They've learned they can do that. And there's these telehealth companies that are sprouting up and hiring people and things like this. But is there any research that tells us what are some of the advantages or disadvantages of telehealth, especially for ADHD or psychiatry in general?
Certainly. So I'll go back to a good friend and colleague of yours and mine, Andy, and Steve. I think you know him as well, Joel Young, who's up in the Detroit area.
Yeah.
He has a large practice with 80 clinicians, and it's a multimodal treatment. They have speech therapists, they have, occupational therapists, they have psychologists, they have psychiatrists, nurse practitioners. They did a study before COVID, and they said, what % of patients were fans of using telemedicine? And their patients said 45% said they would like to use telemedicine for some form of their mental health care. After COVID, they did that same survey among their patients, 95%.
Wow.
95%. So patients are telling us that they like the availability of using telemed for at least some of their appointments and some of their services. Maybe not all of their appointments, maybe not all of their services, but we see very high patient acceptance to use telemed for at least part of their medical health care delivery system.
Well, everybody saw this anecdotally, but it was studied at University of California, Riverside, and actually in the state hospitals. When COVID hit and telemedicine came in, no-show rates basically evaporated. And actually, funny enough, psychiatrists got busier because people came. So it's interesting, the compliance to appointments is better.
Yeah. Mark Stein up at University of Washington, Stephen, has done a very similar thing about using telemed and especially using, rating scales or mental health vital statistics as a way to improve care, decrease no-show rates, and actually improve access because he has less no-shows, so he's able to get more people in for care. In a big academic center where now he's piloting that across his entire university.
Yeah, I think we have to also acknowledge the access issue. We have to acknowledge the fact, as you guys have said, that there are just places in the country that are vastly underserved, and telemedicine may be a way to extend the reach.
Well, one of the limitations I would put then on a telemed model, and this is going to come out in the piece that Stephen and I have been working on with others, is when we ask these 14 experts from diverse backgrounds, when do you think there has to be an in-person evaluation available for somebody?
Right.
We all had very similar views. If somebody's in crisis and needs an in-person evaluation, if you have a telemed model, there has to be a way to get them an in-person crisis appointment. If somebody's not getting better with telemed, there has to be a way to get them an in-person evaluation. If somebody has a complex history where over telemed you can't pick up maybe some of the comorbidities, we need to make sure we have in-person models available as well.
Well, that makes a lot of sense to me. I'm a little leery of these 100% telemed practices, but I'm old school, guys. I like to be in the room with someone. You pick up on things when you're in the room with somebody, and a lot of our communication is nonverbal.
One of the areas, Andy, that it's going to be really exciting, but also it's going to be a little give and take as we learn how to use it, is when we talk about telemed, we have to learn from some of our educational models. We talk about synchronous care, which is I'm seeing you through the computer. I'm having a virtual appointment with you.
Right.
But there's also asynchronous care.
Mm-hmm.
In the same way, there's asynchronous learning where I can see a videotape of a lecture. I can go and learn and read that and read about it in my book now. I can take my test, and then maybe tomorrow I'll have a synchronous lecture as well. Mm-hmm. There's asynchronous models of telehealth care.
Yeah.
I can send a note. I can send a video to my clinician. They may not get back to me till tomorrow about it. That would be asynchronous care delivery. And I think some of our hybrid models will utilize that as another way to reach out and extend care for our patients.
No, that's a great point. Emails and text too, yeah.
What's the difference between telepsychiatry and basically Zoom psychiatry, where you actually have video psychiatry?
Yeah, so that's a great point, Steve. So we haven't really emphasized that, but during COVID, we saw that a big chunk, sometimes the majority in some of the models, had no video component. They were just audio.
Right.
Telephone.
They were just audio. We now know that reimbursement has changed to where most of us are going to have to give a video component to that visit if we want to be reimbursed.
What other changes to reimbursement are happening?
It's a complex, ever-changing world. We live in an office where we take most commercial insurances. We also work with some of the government payers. And everybody has a little bit different guidance right now on where the role of video telemedicine appointments fits. Some people are paying them on par with in-person visits. Some people are giving a slight discount on what they're reimbursing. Some people are mandating that you have to go back to in-person visits. So it's a changing world, to be honest with you. And it makes it complex as a clinician on my side of things, making sure we're staying within the guidance of the people that we're working with.
Now, Greg, you at one of our meetings, you raised something that I was unaware of, that insurance companies are now starting to acquire telemed companies. Isn't that?
100%. And let's use one of our largest ones. United Healthcare through Optum bought a large group called Refresh. And Refresh is a group of mental health providers, many of whom are telemed appointments. Optum has developed their own telemed platform, Steve. And about a year ago, they came to us as clinicians and said, if you don't use our platform, we will no longer reimburse for care.
Wow.
And we said, guys, we can't roll on and off 3 different platforms or 4 different platforms all day long with different patients. That's not going to work.
Yeah.
So up until now, they haven't mandated using their platform. But you could come to a model where you see that in order to get reimbursed, you have to use that insurer's telemed platform.
I'm sure that's absolutely true. So there's not a good harmonization, if you will, of these things. And I know there are many different vendors out there. You had mentioned you use Doximity, I believe. There are many others.
Yeah, so I've used a little bit of everything, Andy. So I've used Doximity. I've used Zoom. Mm-hmm. We are using Advanced MD is who we're using currently. Mm-hmm. And I'd say no one provider is perfect. They all have some gaps in the system. Yeah. And what we would love as clinicians, we'd love to have, the Microsoft of telemedicine that just helps to standardize things for us. But right now we're not there.
Yeah, this really is an evolving field, isn't it? The field of telemedicine. We're to some degrees in the early days and almost in the Wild West of this. And there's a lot of forces that are pushing on us to shape this, as we've discussed. Vendors and payers and the government regulations. So I commend you guys very strongly for trying to develop these expert consensus guidelines, particularly for ADHD, but of course it's an issue with all of the conditions we treat. So, guys, it's time to wrap up. I can't believe this has gone by so fast. There's so many wrinkles to this and aspects to it. But Greg, any final thoughts you have to help our audience wrap their heads around this new world we're in?
Let me just start by once again, it's an exciting time to be in mental health care. It's an exciting time to be in brain health. So we have a lot of new options coming out. We have digital options. We didn't talk about the world of digital therapeutics, Andy, and we're doing a lot of trials looking at digital interventions for ADHD.
That is true.
We're in the middle right now of developing other new non-stimulants that hit the brain differently for ADHD. Mm-hmm. And then how do we leverage that with knowledge and education to get the right treatment for the right patients? So it's an exciting time to be in brain health. We have a lot to offer. There's some hurdles we have to get through, but we're all going to do it together. And I would say for all of us, whether it's your group of listeners out there at NEI or the people I work with at AppSard, we're all one big family working together, trying to move the needle.
Yeah, I mean, we know that technology is going to change the way we deliver care. We just don't know how yet. And of course, we haven't even scratched the surface of AI and how that's going to change the whole world. Steve, what are your thoughts here?
Well, I'm just thankful that we left on this up note, and Greg's a very inspiring point of view and optimistic outlook on things. Yeah. I think, it is a great time to be in mental health. The neurobiology basis has never been stronger. Treatment options are exploding right and left, a lot of innovation, technical backup, whether it's, as simple as telemedicine and beyond. So I hope our listeners are proud and happy to be involved with mental health. It's a great field to be in, and I think the future is bright.
Well, I couldn't agree more, guys. And I want to thank you for your time here. And I want to thank you, the listening audience, for spending some time with us on this podcast. I hope it's been educational and inspiring to you. And please stay tuned. Come back for the other podcasts in our series, the PsychopharmaStahlogy Show. And for other NEI podcasts and other NEI educational offerings, please visit our website, which is www.neiglobal.com. This is Dr. Andy Cutler signing off. Thanks so much.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.